I have 12 o'clock noon, so we will go ahead and get started. I'm Becky Royer. I'm the MBQIP lead for the State Office of Rural Health. And as always, we want to thank Joyce Fillenworth, the State Office of Rural Health Manager, and David Conrad, the Flex Coordinator, for providing the funding to support our Swingbed education efforts and technical assistance support. I also want to thank Carolyn Miller with the Indiana Rural Health Association for supporting the Zoom platform for us today. Please open chat and also click on the participant list, and you can access those by hovering the bottom of the screen, and you'll see both the chat icon and the list of participants that are on today. You are certainly welcome at any time to unmute your line and ask a question to Kerry and myself. You can do that by clicking on the red microphone beside your name. And hopefully everyone will be able to mute their lines so that we can cut down on background noise. Likewise, if you have difficulty unmuting or don't have a good microphone on your computer, please feel free to chat in any question, and we will make sure that it is addressed. The presentation for today was distributed this morning, and at this time, it's my honor to turn the meeting over to Kerry Dunning, our National Swingbed consultant that has been wonderful support to us over the last couple of years and helping us build good, solid programs. And I definitely think that assisted everyone in having good, solid programs during the public health emergency. So Kerry, I will turn it over to you.
Thank you, Becky. That's very kind of you. I appreciate it. I like working with people. The nice thing, since I'm one of those older adults, is when I get to this part of a job is you can choose more of what you would like to do. And trying to see this program work for rural health is high on my list. So the topic I've picked for today, which you'll be glad to know, it says that C word every once in a while in it. Because of federal regulations, but basically beginning as once you can take a breath in Indiana, looking at how we handle our swing bed programs. Are we keeping people the right length of stay? Could we keep them longer? What diagnoses could we be looking at? That's the direction I would like to take for the next couple of visits, with doing different pieces each time, so that we know coming out of the mess, particularly some of you have been in Indiana, that there is a way to manage this and cut down a little bit of the stress level on that. So I want to go back to basics. As you remember, the skilled nursing rules are the baseline for swing bed programs, whether you are a rural hospital or a critical access hospital. So the basic for skilled care has always been that Medicare covers up to 100 days for each SNF benefit period. Once those 100 days have been used up, then they cannot get a new 100 days unless they have been out of a hospital or out of skilled services for at least 60 days. And we had maybe 15, 18 years ago, this took a big turn because we had people, for instance, on tube feeders that they weren't going to get off after 100 days. It was going to be permanent. And CMS said then they will not ever be eligible for skilled care again. So it's important that you realize, and your staff, when we're doing our homework, is checking available days, and before you are admitting. But if they're out of a skilled service, they can be eligible for a new 100 days. And the rule that is written right there says after a 3-day qualifying inpatient stay, because this slide is based on regulation. The waiver of the 3-day, and it was a waiver that is still in place. And there has been discussion that they're going to permanently get rid of the 3-day requirement, but that hasn't occurred and we're not out of the waiver. But once we are, we would go back to the 3-day qualifying stay unless regulation and or law changes. And always remember that this is based on skilled need. And I like to make it pretty clear that it's not always just PT and OT that should qualify somebody. And I say just kind of in quotes, because Medicare's stance, and I think it's probably correct, if really all they need is PT and OT, could they have not gone to outpatient or to home health and gotten those services? What is making a skilled patient is the fact that we need 24-hour nursing coverage. And that's where we have talked for different times during the last year about how important it is to have the documentation, the nursing documentation, even if it's primarily a rehab patient. And that's the basis for this. Medicare will allow, if you get to 100 days, they will no longer pay your room and board, which is the biggest expense of that daily rate you're getting paid. But you could keep somebody there and they could pay out of pocket and continue their skilled services. I would bet 99% of the time that's not what happens. Patients are discharged to home health and they get their PT and OT that way. So that's the existing rule. And if you go to the next slide, please, I want to talk a little bit about something that happened during the waivers. And just for the purposes of checking on this, I called a couple consultants in the last 2 days and said, how many people are really taking advantage of an extra 100 days? And the answer was, you'd be really surprised, a lot. Most of those will be skilled nursing facilities, because when somebody is in a skilled nursing facility and needs Medicare services, their length of stay is longer, their complications are longer, because they are now ultimately really probably going to live in that long-term care facility. Where our swing bed patients, we may have them clinically complex that will go to a long-term care facility, but a lot of ours are going home to outpatient or home health. So under the PHE waivers, remember in March of 2020, when we were trying to get all that language in our head, CMS allowed for an additional 100 days under skilled coverage with some requirements. Primary one that I haven't written, because this should be written on all our foreheads, is that you have to need skilled services. That has to be very clear, and that goes back to the documentation you have or you don't have. And then they clarified it a couple times in March through May, back again in 2020, and issued some letters. So basically, the statement that came out is the second bullet point under that: have coverage for an additional 100 days in a SNF without satisfying a new benefit period in certain COVID-related circumstances. They came back with another letter and said COVID does not have to be one of the diagnoses. So basically, a skilled patient who has critical enough needs that and is complex enough that somebody is staying in, I'm going to say, in a nursing home for 100 days plus needing more days past that is a pretty sick human being. So during the emergency that we have now, the public health emergency, there are nursing homes where there are a fair number of people that are rolling into an extra 100 days. I have not heard that in a swing bed, and honestly, I would be shocked if a swing bed has done that in this country. I would think if they were not stabilizing after a certain time period, they would be referring them to a skilled facility because it was going to be a long-term healing process. And again, I put there for the DR code, just remember, if you're using any of the waivers on our claims for skilled, the DR is disaster-related code, and your billers should know that. And what you have to remember is when the waiver ends, I'm pretty sure this extra 100 days will go away, so don't go jumping on a bandwagon. If some of you have used 100 days, which again, I have not heard anybody using it in a swing bed setting, just make sure you are reviewing your documentation before you close a chart. All right, the next slide, please. And the basis for those 2 slides and comments is even before we had COVID in our language, there was some feeling that swing beds were releasing patients too quickly. And I'm going to have to say I'm walking a fine line here, because I want to leave that to professional judgment. I'm not in your shoes, and I'm not looking at that patient in that chart at that moment in life involved with that physician. But a length of stay, I had a number of times where PT would have somebody 7 or 8 days, it may have been OT too, but a therapy the department would have a patient and they say, we can't do anything else, send them to the skilled facility. And we heard that as a normal statement. And there's two things wrong with that statement. One is one of the rules for skilled care or hospital care or home health is you must be able to take care of all the needs of that patient or you shouldn't admit them. The best example I usually give of that is a new stroke. If you have orders coming in for PT and OT and not speech, but it's a new stroke, that means there is the potential for need for speech, for cognitive or swallowing difficulties with a stroke patient. You should have access to speech pathologists before you admit that patient. So that's when we're talking about admitting, being able to care for the person. In all fairness to therapists, they have lived in a world where they have been taught to do everything quickly. You know, there's no extra money under a DRG payment for therapy. So they do basic inpatient. Outpatient therapy has come down to visits and certainly limitations on those visits. And here comes the Swingbed program, which is like the nursing home down the street, but your hospital-based therapists, whether they're inpatient, outpatient therapists, are not used to that. They're used to getting them out the door quickly. And I think we were running into ourselves trying to cover that. More lately, pre-pandemic, because our length of stay is all over the place with the pandemic, but pre-pandemic, we really were keeping rehab patients around 10 days and medically complex around 19. And the medically complex had started going up in the last 18 months prior to the pandemic. As you know, we've been getting sicker patients with more needs. And so one of the things, for instance, that would influence that would be a 30-day antibiotic, took that number up a little bit. But many programs, when I look at them, we're discharging Swingbed patients before 14 days. And it's almost like it's an automatic that somewhere in your program, you've got an idea. I don't know where it has started, but an idea that, gosh, by 14 days, we need to get them out of the door. Some of that, honestly, is a fake number. If you were a rural hospital and had to complete an MDS after day 14, a new MDS had to be completed under the old system, and MDS people don't want to do another 40 pages of work with good reason. So I think it became an arbitrary number. In critical access and other rural hospital Swingbed programs, the other arbitrary number became day out by day 21 or discharge on day 20. That's been tied back not to any regulation. You are under the skilled rules and can keep them up to 100 days. It was tied to the copay coming into play on day 21. I have many Swingbed programs that take patients, and when they take them, they know they're probably going to need more than 20 days, and they either accept the copay or they bill the patient, and if the patient can't pay, then that ends up in a cost report issue. That's up to your system or your hospital to figure that out, and your financial people. But many now have started going past the 21 days. What I'm going to suggest here is look out for the arbitrary numbers. If you're discharging by day 14 or by day 21, those are arbitrary numbers that have anything to do with the care needed by that patient. So be careful setting those patterns. Beyond that, I think we're going to have to look beyond 21 days for our skilled patients in a Swingbed, because we really are getting clinically complex patients. They're getting sicker and sicker with more comorbidities. We have IVs running longer. We have piggybacks. We have all sorts of things, as we've discussed this year, that nursing homes really at this point have not been able to take, COVID or not COVID being present in that equation. Excuse me. So I'd like to suggest to all of you that you look at types of patients you're taking. What kind of diagnoses are you admitting now? What's your length of stay, I'll say, prior to the pandemic? Pandemic has changed numbers. And again, I think we're going to put brackets around 2020. It looks now like through 2022, and just say that was an anomaly to all of our projects at that point, or our way we were accounting for them. So look at what your length of stay was. What is it now? Do we have a pattern of discharging at day 20? Why? Do we need to talk to the financial people about what we're going to do about copay? you need to look at the percentage of your admissions and comorbidities. People that are going to have more trouble healing if they've come in for CHF and they already have COPD, that's not going to be a quick fix in most cases. And we want to send them home as well as we can get them reasonably. And you know that everybody but critical access swing bed programs are being penalized for readmissions to hospitals and visits to ED within those first 30 days. So we can help with that. So the other piece that I'm actually now on one CMS committee and 3 state committees looking at long haulers. And those are the patients that have finished with their initial bout with COVID-19 and either immediately or even months later, some of the 30 and 40-year-olds we're seeing coming in with long hauler syndrome or symptoms. I've heard all sorts of names for it. It's actually PASC is the official name for it, but the long haulers, they can come in 4 and 5 months later and have had nothing in between. So what are we going to do if we're looking at an aging population already with comorbidities who have now been substantially weakened by a COVID time period for them? What does that mean for how we're going to treat them? CMS is mentioning it in almost all of their waiver programs right now. There's a waiver program that I'm involved in with a couple of states called Hospital at Home. And CMS has directed, I think there's 67 hospitals that they've allowed to sign up for at this point. And they're gathering data on how can they pay for this, knowing that we're going to have a huge population, whether they're skilled, acute, post-acute, meaning outpatient type of patients. How are we going to pay for these guys? Long hauler by definition can be 5 or 6 months, and it could be forever. It could be years. We don't have the data to prove that. So the question is, in your area, are you beginning to see long haulers? And how are we addressing that in our communities? But certainly post-COVID patients or COVID patients, if you have been accepting them, is a population that's going to need care that fits this clinically complex discussion that we've been having. And I think the other question, because all of those are good clinical questions and program questions, but it really comes down to something that comes from your administration, particularly probably your financial side, is how many beds do you have available for swing beds? We've already gone through years and years of knowing when we hit flu season that we probably should be admitting less swing bed patients so that we have acute beds available for flu patients. I would be very happy to have COVID go into a season instead of a year-long event, but we're going to have to say how many swing beds do we have? What do we available to us? How many beds can we use? And what does that mean realistically? And I'm going to suggest in this year ahead, as we look later into 2022, I'm going to see, I've already started seeing, I think you're going to see in Indiana, people beginning to really do specialty type programs, whether that's post heart surgery or whether it's pulmonology, whether it's neurology. Again, all of those are side effects of COVID that they could have had an underlying cause and COVID set it off to another degree in them. But you may need to be finding something that fits your program, your training, your physicians, what your area needs. And area means more than your immediate county. And for some of you, maybe even what your system needs, where they can transfer patients to your swing bed program. But I think it's a time we start looking at and asking what we want this swing bed program to do for us, and why we are still kind of coming out of the COVID stage, but looking forward. And all of this, as we've discussed for the last year, is we are getting more clinically complex patients. We're an aging population, more comorbidities. I asked somebody the other day, some nurses actually in a meeting, when was the last time they saw a patient on less than 10 diagnoses of some substance or less than 10 meds, and they were out of about 80 people in the room, 2 hands went up. So we're getting sicker people. We've got some work to do in front of us, and the swing bed program is a really good way to try and get people home and stabilize them and assist them back into real life. But clinically complex patients are going to require longer lengths of stay. So I think it's a time for you to have internal discussions with your leadership team and see what fits for you, because this is going to be either your own hospital decision, or if you're in the system, maybe it's a decision within the system. But I'll leave that up to you. So Becky, that's what I'm trying to work with these days, to get people to start looking ahead a little bit, since we have been caught in the midst of a pretty significant event for the last couple of years.
Thanks, Kerry. Kerry, I also want to thank you for bringing to our attention some of the reimbursement issues that were happening in the other states where you work. And pleased to say that so far, and I want to thank everyone who responded to our inquiry, that we are not experiencing reimbursement issues here in Indiana. So, but
Which is great.
always want to stay on top of those things, because definitely our critical access hospitals do not need one more thing to deal with.
And Becky,
Go
one
ahead.
thing, I do think that's because they were critical access. Because when we've gone now, I've now got 9 states that are having problems, and it's with Medicare Advantage programs. And basically they're asking them to change the PDPM score, which is illegal. Not that they're trying to, the plans are trying to be illegal, but the programs cannot change it without redoing a whole MDS. So I would suggest that you keep watching it. And if you see a pushback, it seems to be coming from Medicare Advantage programs first. And that may be, Becky, when you want them to contact you, so we see if a pattern's starting, to see what we can do about it.
Perfect. Yes, please reach out anytime you have any reimbursement types of issues, and we'll see if we can't be of assistance. Kerry, I did have a question come in prior to the call. In one of our critical access hospital Swingbed programs, physicians see their patients every day or every 7 days and attend the care plan conferences. Is an overall complete assessment or exam every 7 days required, or just a note in the medical record? And if so, how often can the physician bill?
Okay, those are, I think that's multiple questions. So let me try, and Becky, double back check me here to make sure I
I
go back
will.
through them. All right, so first of all, the physician is supposed to do that, I'll say, more full-blown exam. You guys have it in your policies, what needs to be done, and that's done at admission and discharge for sure. And if there's a significant change, then we would want a more intensive review by the physician. So, and you again know the definition of significant change. It is federal law, number 2, that the physician be in the IDT meeting. And most of you have gone to IDT/care planning as one meeting for each of the patients, whether you do it individually in rooms or otherwise. So the physician should probably write a note with you, the rest of your team that's in that meeting, as to what was discussed about the patient, particularly if he or she recommended something or adjusted a medication, for instance. So we're talking about a progress note basically coming out of IDT. That just shows that the physician was involved, if not with everybody, literally everyone, the majority that he or she again was input was sought and used. There is no limit on the number of times they can visit. What does cause problems, number one, if there's a pattern, like if a physician goes in every 3rd day on every patient, that's not medically necessary unless you have sort of exactly the same kind of patients, and that's pretty rare. I would make sure that, and you don't have to go in more than once every 7 days. And I say the 7-day period mainly because the swing bed stays tend to be shorter, again, than the average length of stay in a nursing home for skilled is at 37 days prior to the pandemic. So they're lengthier. But he or she needs to go in because there should be some notes in there from nursing in particular that have requested the physician to intervene on something, whether it's a lab test or whether it's an x-ray or whether it's decline in the patient, whatever. At that point, he or she should go in, and we want to make sure that we, again, have a progress note. And it's really nice if we have a tie-in to therapy or to nursing or to respiratory therapy, for instance, or even to pharmacy, asking for that physician involvement. That just backs up the need for that patient. Does that answer the question?
Yeah, so every 7 days, there should be some type of note then from the
Yeah.
physician?
Well,
Okay.
every 7 days, we have to have an IDT meeting. And the physician, remember, is the first one on the list of those required in the IDT.
Right.
And I'm suggesting it, he or she is sitting there, whether it's Zoom these days or literally at a table or at a bedside. It's helpful if we have his or her input on the decision made by that team. That can be a very short note that the physician's still worried about a specific lab, for instance, or a specific whatever, and that will be monitored. It's not anything that has to be the great American novel. It just shows the team was working together and that physician was involved in the care planning and interdisciplinary team.
And there is a question again in chat. Is a physician able to charge for this visit?
Yes.
Yes.
There's not, this isn't, I think where we get caught up, it used to be with long-term care, not skilled, but with long-term care, the physicians visited once every 30 days initially, then it goes to once every 60. And so physicians got worried and there was some kind of flooding back on, if they had to go in between, which led to physicians sending patients to the emergency room rather than seeing a patient in long-term care because they couldn't bill for it. Medicare has sort of tamed all that down, but that's where that concern, I think, has come from. We're in a skilled setting. For most of you. It's being driven by clinically complex, medically complex patients that can change on a dime, that need medication changes, need lab work done, need scans or x-rays done. And that's why the involvement of the physician is so important in your setting. Now, I know all of you know that, but what I would ask you to do is check your chart and to see if you are getting a recording of what recommendations or what involvement that physician has had in this process for you.
Okay, thank you. If there's any other questions around that, why please chat that in. Kerry, you mentioned earlier about patients preferring to stay in the swing bed and paying out of pocket. And I do want everyone to know that during COVID, there have been a couple of situations where some hospitals have had that request come from the patient, and they really needed to beef up their policies and procedures around if a patient would like to pay out of pocket, to make sure that you have good processes in place for that. It's kind of one of those things that are situations that don't particularly happen very often, but could. And now patients are much more cautious about going on into a skilled nursing facility. So there may be times where they do prefer to pay out of pocket. So please make sure that's addressed in your policies and procedures.
And that's a great point. Just to be clear, what I was referring to is when they get to the end of 100 days, and most swing beds don't have anybody getting to 100 days, but under the Medicare regs, when they get to the end of 100 days, that patient could stay in that nursing home as a long-term care patient, but continue with PT/OT being paid by Medicare. So that's that discussion. So we do have some people that want to pay privately, and there's nothing that from day one, you can't accept somebody that can pay privately. For instance, maybe they don't have insurance or aren't covered by Medicare or whatever. That's up to you. But yes, exactly. Any decision, particularly financial decisions, should really be clear in your policies.
The other issue that has come up here recently is COVID's had its impact on home health as well.
Yep.
And some of our patients have been experiencing some delays in home health being able to get in to see them at the appropriate time. Any suggestions, or are you seeing this in other areas of the country?
Yeah, and I don't think this is going to be one answer. I think this is professional judgment. If you already know your area is having trouble accepting home health patients, I think that's part of your team discussion. So for instance, if that patient really still needs PT and OT, and there is and obviously that goes back to our discussions about second shift nursing notes. When people are weaker, more likely to fall, need maybe a 1-person, 2-person assist at night, that kind of documentation will allow you to keep somebody longer in the program. If they don't need that, and you're going to, again, it's going to have to be your professional judgment. If they really don't need that, then we're going to have to send them home with warnings for family, et cetera, on how to care for this patient until home health can get in there. So I think that's a fine line that it has to be individual patient decided. It can't be a global statement at this point.
Mhm. Likewise, I think some of those follow-up phone calls as patients
Absolutely.
discharged are very helpful.
Absolutely. And one other reminder, remember, within 30 days, they can come back to your Swingbed program. So if you send them home and they're going home by themselves or to an elderly spouse, and that person, whichever one, calls and says he or she is falling, I can't take care of them, you can bring them in back under the same diagnosis. So that's also something to consider if something's going on at home. And that may not only just be falls, although that's one of the primary ones. It may be they're reacting to their medicines or not taking their medicines right. But you can bring them back as long as it's still related to the hospital stay and within 30 days of discharge from your Swingbed program. So don't let that go unused. That's been used a lot during this pandemic. Correctly, by the way.
Yeah, interesting you bring that exact point up because I am working with a small group of critical access hospitals here in Indiana and also doing some benchmarking against some other states. And something that we are seeing is that the other states do readmit back to their Swingbed programs more readily than we do here in Indiana. So we're going to take a deeper dive into that.
And it's a good thing to look at. Again, I don't want to, if any of you ever say, well, she told me to do it, that's overutilization. I didn't tell you to do it. Just want to make sure I'm clear on that. But many of these guys are older. And you've heard it. If you've been around the spouse says, I can take care of him or I can take care of her. And they go home and they can't. When they're trying to get somebody out of bed to go to the bathroom at night, they're dead weight. They've been medicated, they're tired, etc. They can't care for them. So as long as there's medical issues, which in that case would be, a therapy need still, you can bring them back in. That's a safety issue. That's cutting down those ED visits that might have been unnecessary if we'd gotten them a little safer. It may be caregiver education has to be part of that. It won't be the only reason. But that we have an awful lot of return to hospital within 30 days. That's why there's a penalty for everybody but critical access. And I mean everybody, primary care providers, everybody has a penalty now. So the follow-up calls are critical. If nothing else, even a follow-up call, you may be able to prevent a readmission or a visit to ED, because if somebody's confused about the meds and you can answer that on the phone, you've just stopped a potential issue from somebody needing additional health care.
Thanks, Kerry.
Yep.
Any
and
other
I am
questions?
slightly passionate about that on purpose. I think we've got to give people their fair due to try and get them home safely.
Agree. Any other questions for Kerry today? Again, feel free to unmute your line or chat in a question and we'll see that it's addressed. So we'll just pause here just for a little bit to see what is most pressing on your mind today.
Well, while there's a pause, I want to thank everybody for all the work that you're doing. It's just amazing what frontline people have done in all sorts of businesses, but particularly healthcare. It's stunning. I know you're probably tired and worn out and fed up with lots of things. So just know there's more than me. There are a lot of us out here and it's not going unnoticed. So thank you.
Absolutely. Agree with you 500%. So I'm not seeing any other questions. So I think that will wrap us up for today. So big thank you to Kerry for sharing her words of wisdom and guidance and support. And thanks again to all of you for joining today. We will send out a recording of the event today if you'd like to share with others in your organization. Have a wonderful and safe day. Thank you so much. Bye-bye.
Thank you. Bye.